Use of technology in developmental pediatrics by Professor Dr. Sheffali Gulati, ma'am. Ma'am, please. Ma'am is a pediatric neurologist, and as pediatricians, especially middle-aged and senior pediatricians, most of us are technically challenged. So probably how we can improve, how we can become more tech savvy, especially when we are going to practice developmental pediatrics. That's a real challenging issue, madam. Over to you, madam.
Thank you. At the outset, I thank Dr. Subramaniam and all the other organizing team to have called me. So can I have the first slide, please? I have 20 minutes. I'm mindful of time. I would be giving you a brief overview of how exactly technology can help us. And it is not only in the air, it is in factual practice, so what we can actually do. So can I have my first slide? And you please start my timer when the slide comes. Yes. Yeah, so you have to have this time. So basically what in developmental pediatrics, we are all handling basically neurodevelopmental disorders which actually cover most of the pediatric neurology and developmental pediatrics actually. Can I have the, okay, I can do it. Okay, I have no disclosures and I dedicate my presentation to all the children and their families who have special needs. And basically, what are they? Just a brief overview, what is the prevalence and what is the need of the hour, and how this technology is going to help us in fulfilling the need, plus what are the advances in technology which are there and how we can move ahead. So basically, we have to look at each problem, whatever it is, not as a disability, but as a challenge to move ahead. And that is how Shane Brand, who had dystonia, looked at it. So we have to not get disheartened, and for us as medical professionals, I understand that we have all allied professionals as well here, but we should look at the capability approach, what the child can do, and we have to help maximize his or her potential. And disability is basically, this slide is there for a health condition along with personal and environmental factors which are modifiable. The health condition has to be taken care of, but the attitude of people around you and whether the surrounding around you is environmental, is friendly to the special needs is very important. And it is very important because it is contributing to our 25% of disease-related mortality, and what we can do is three things: primary, secondary and tertiary prevention. We have to prevent an impairment at an organ level from becoming a disability at an individual level, from becoming a handicap at a societal level. Primary prevention is when you understand from research what is causing it, so as you prevent from its occurring. Secondary is what we as pediatric neurologists and developmental pediatricians do, is try to pick them up early. And tertiary prevention is the rehabilitation, and it is not only using mobility devices and vision and hearing aids, it's much, much enhanced. So we keep talking about inclusion in school. I think we have to talk about inclusion in society as a whole. And neurodevelopmental disorders encompasses so many of these conditions, just to keep in mind. And with the smaller, sicker newborn being surviving because of SNC used by the government of India, pan-India, and sicker children are surviving in the pediatric intensive care. So you're having a paradigm shift from improving survival to the upcoming neurodevelopmental challenges. And we are an MIC have all this poverty, poor stimulating environment at home, malnutrition, both of the mother as well as of the child, and other environmental things. And that is why the government is focusing on first 1,000 days, including the pregnancy. As regards the prevalence, the only prevalence study which we had done, which was with Dr. M.K.C. Nair, SPI, Dr. N.K. Arora was a team leader, I was the network coordinator of the project. And we found the prevalence to be around 12%. That was one in at least, 1 in 8 children having at least one NDD. And 1/5 of them had comorbidities. And it goes around, the prevalence in the world is around 7.6 per thousand. And the prevalence we did was by population proportionate by size sampling, prevalence studied in 2011. And although the publication is 2018, but the prevalence study was in 2011, and that was 12% children in the age group of 2 to 9 years had neurodevelopmental disorders, coming as 1 in 8, and 1/5 of them, 21.8%, having comorbidities, making it important for we as pediatric neurologists, development pediatricians, and all the therapies and all the professionals to understand the child has to be holistically evaluated for the comorbidities, otherwise we cannot optimize their maximal function. And the autism, which was prevalence, was 1 in 89 way back in 2011 data. And this is rising, and now it is 1 in 36 according to CDC of March 2023. So I mentioned to you now what we need is primary, secondary, and tertiary prevention. Then second is early identification, having the socio-cultural sensitive tools. Third is empowering professionals. Fourth is empowering the parents. And the primary prevention is because the classical example is folic acid, yes, as we all know, but newer things are coming up and we have to study. By research, we'll be able to prevent. And pre-implantation, genetic testing and diagnosis is something which will be something of the future. And secondary and tertiary prevention, I have already mentioned. Then we need to have socio-culture sensitive tools, and they have been developed as a part of INCLIN study, and later on, after that, we had taken it forward. And the INCLIN study was 2 to 9 years, but we have taken it forward. This neurodevelopment screening tool was there from 2 to 9 years in the INCLIN study, which has 11 questions, and it is used in the RBSK. And this is 2 to 9 years. So we did the ages and stages questionnaire. We did a socio-culture adaptation of this ages and stages questionnaire and did a validation, and we have good psychometric properties. And this is now being used for training of the TOTs for the high-risk newborn follow-up in the Indian Academy of Pediatrics now, published in Indian Pediatrics. And then, you have this AIMS modified INDT ASD tool, which is in DSM-5 based, in consonance with with ICD-11, and the whole thing, because the old INCLIN tool was DSM-4 based, because that time DSM-4 was what was there, and DSM-5 came in 2013, and we had done the study prevalence in 2011, as I mentioned to you. So this one, the DSM-5 based tool, has been published in PLOS 1 in 2019, and it has very good psychometric properties. It also has a scoring system there, which is there. You can have the severity, which has been tested along with CARS, and we have also developed, that tool is now for 1 to 14 years. This one for 1 to 14 years. Old INCLIN tool was 2 to 9 years. Then we have also developed another tool, 1 to 18 months. So we have in 1 to 6 months, 6 to 12 months, and 12 to 18 months, and we have been able to pick up with good sensitivity and specificity these high risk children, so that we can do an early intervention. And you have the ADHD tool, which is there from 6 to 18 years with very good psychometrics, published in Neurology India, and 2020 an epilepsy tool from 1 month to 18 years, and this is published in Epilepsy Research with very good psychometrics. And also the neuromotor impairment tool, which was to pick up a child with a neuromotor problem, which can be either cerebral palsy or neuromuscular disorder or post-meningoencephalitic or post-stroke sequelae, and that is published with good psychometric properties and published in Frontiers of Public Health. They all are the old INCLIN tools are being used in the RBSK and was used for Gazette for ASD certification. That's being replaced by the AIMS modified INCLIN tool. How technology is coming? There's an app there now. You have the app, PedNeuroAIMS Diagnostics, which is freely available on Google and Apple Play Store, in which all these 4 tools are put inside, and you can, you can put the age of the child, and your age-sensitive questions will come up. In autism, what you have to see and what you have to observe, and if there is a discordance between what you are seeing and and asking the parents and what you are observing, then which one to give importance, asterisk is put, and the algorithm runs in the background, so that it will be easy for a point of care professional to apply these tools, right? So that is something important. And secondly, is the next point is the training of these. We have this website, which is www.pedneuroaims.org, which has all the various neurodevelopmental disorders and relative, material along for that, and that can be taken studied. And we have developed a 2-pager developmental milestones checklist for any pediatrician, practicing pediatricians, and also MD residents, so that you have all the milestones and the red flags, so that they can pick up. And we've also made a development kit. And all this, how to do examination, developmental and neuro examination, is on the website. And we have been training the master trainers for certifying autism, and now we have been assigned a task to make it into a certification course, which is coming shortly. All these modules are available on the website, or the mass training of trainers and everything. All the resources are there on the website. Plus, we also have e-learning modules. Lastly, but not the least, is empowerment of parents. How much time do we have in our busy, outpatients to tell everything to the parents? Yes, we do counseling, we have to do, but we have to give them some resources in their regional languages. We made it in Hindi and English. Some of them have translated into Telugu and Kannada and all they have done after asking writing to me, and obviously in Bengal, it's also there in Bangla, and they have also been using in, Bangladesh. So empowerment of parent is important. We have parent information material on various neurodevelopmental disorders, and parent information videos are there. They are all only catering on the website are English and Hindi, and various aspects including domiciliary management of seizures, the videos, everything. They have to be told. They should have a resource for understanding, for CP, modified constant induced movement therapy. We've been doing studies that hemiplegic CPs or asymmetric CPs, it works. Structured exercise program, you keep telling and all, but you should give them a resource in which they can have access. This is all there on our website as well. And all this is there, and we have to, we have to translate into the regional languages and for it to be available. So these are all videos also, and along with the Government of India, we have been encouraging and identifying autistic marvels, and we have been felicitating them at the Government of India level. And we have a Center of Excellence in Advanced Research in which we have national registry we are developing for all the neurodevelopmental and neurological disorders as one consolidated registry, should be coming out before the end of this year, and National Knowledge Training Center, Advanced Diagnostics, and we are trying to work on for the development point, we have been working on autism, and for last 5.5 years, we have been studying RACGH as a next generation sequence, then whole exome. We'll have all the data of Indian population out before the end of this year. And working on autism and CP focus, we are working on virtual reality, robotics, mobility assist, and artificial intelligence, as well as brain-computer interface and robotics, and also trying to work on music therapy. Much before the COVID, on 13th of April 2018, we had launched a child neurology telehelpline and teleconsultation services, and we had done, after doing evidence research, that we are not going to miss a critical clinical event if we avoid a face-to-face contact. And why did I want to do it? I wanted to do it, most of these conditions last across a lifespan. Very difficult for parents to keep on taking absenteeism from work. So it was important that if we could have done it without causing any risk. So we did them study in neurocystic cirrhosis, we did study in other epilepsies, like LGS and infantile spasms, also in DMD and all, and then we did it with the nurse and then pediatric neurology fellow, and then ultimately this was launched. And we have it SOP done. Right now I'm trying to collaborate and do it into a multilingual teleconsultation. And during the COVID times, when we had done our meta-analysis, we had seen that most of these children with neurodevelopmental conditions had worsening of the symptoms after studying data from 23,000 children. Role of technology beyond what is currently being done is virtual reality. One thing, it is there. It is the only problem is when you have a ball hitting at you in the virtual world, it's not going to cause you injury if you miss it. But in the real world, it will. So, but still, there is a lot of focus on cerebral palsy, movement disorders, autism, and ADHD is being used. And artificial intelligence is what? It is basically simulation of human intelligence in machines. They think like humans. They mimic their actions, and what we are actually talking about is augmented intelligence, in which they do not replace but create systems they are going to help. It is augmenting human decision making. We are not talking about replacing humans, okay? That is something important to remember. And if you see the data, maximum work has been done for autism, and next for dyslexia, and then in ADHD, if you see global literature. In CP, they have started having wearable devices for monitoring general movements, and eye gaze for these children, brain imaging caps. Then for therapeutics, they're trying to do non-invasive stimulation, transcranial magnetic stimulation, augmentative alternative communication devices, virtual reality and robotics. And it has been, it's something there, and for the artificial intelligence can be used to develop algorithms for diagnosis, and then like in mobility devices to navigate the various terrains can be helped. They are also using some genetic data to understand through machine learning whether you can predict having a CP. Then this general movement things, there are a lot of sensors which are there. There are a lot of studies being done on general movement assessment, and in which they have developed a lot of algorithms, AI based, to predict, have them prediction models from general movement assessments. And simple things, we don't think about it. I just wanted to put feeding utensils and devices, having something for writing aids. They are very simple, but technology can have a little, it's not high end, it is a very low hanging fruit. These simple things can help these children. We keep talking about the anterior walkers. We don't talk about the posterior walkers. It's something very important to be talked about. We did a virtual reality assist modified constraint-induced movement therapy versus constraint-induced movement therapy, and we did find that these children did really well when they were getting assisted by the computer through the video program, how they were doing, and it was really working very well. And then we went ahead and did a transcranial magnetic stimulation, in which we had done in a hemiplegic cerebral palsy, we did it on the contralateral side, and we found very significant improvement in their hand function. And this has been published in, recently, in May it was published in the neural rehabilitation and neural repair. DBS is also being done in some of them with you have focused dystonia in CP patients. Robotics can be either, they can be helping you, aiding as augmentative, or alternative. You may have exoskeletons in which you will have to big lot of support, and it is there in India. It is not that it is all not there. There is some robotic crawlers. This is not in India so far. For infants, they have started in the West, and where there are a lot of gait training robots which are there, and those who are severely affected, you have exoskeletons which are there. So gait training has shown a lot of benefit. The robot-assisted gait training has shown a lot of benefit. It has been very promising, and they're also studying on neuromuscular stimulation of aided walking technology. And also this is, when the child is made to walk on a treadmill in a virtual reality environment, trying to get a guidance upon the gait feedback. And we have developed, along with IIT Delhi, an artificial intelligence-based real-time clinical support system for a gait assessment in these children to plan what can be done. Next part will be the intervention. So you can have mobility robotics, virtual reality systems, alternative augmentative communication systems, self-care robots, and mobile applications for them. For autism, quantitative EEG, fMRI, and eye movement tracking, and artificial intelligence can be used for diagnostics. Therapeutics, you can have assistive technology like compression jackets, earbuds for calming the children, and transcranial magnetic stimulation, artificial intelligence and robotics, and virtual reality, augmented reality. Let me tell you, we're doing practically everything. So it is not something which is there of the future. You can have this virtual reality through this, the eye thing is there. The child can see in the virtual game. This is a virtual reality which we have developed. We have developed a software which has been worked in autism patients for temporal and spatial prediction. Then augmented reality also, this we have developed along with IIT. For virtual reality, joint attention training platform has been developed. And then we also developed, that as augmented reality joint attention training platform. So, and we are developing AI-based robots for improving the prediction skill for these children. If you see the analysis of AI-based studies for, for autism spectrum disorders, you can see the number of journals and mostly the continents where the studies are being done. And you see the number of studies which have come up. 1995, one study, and now you see 2020, how many publications coming up. So these are some things which can help us in rehabilitate our children better. Artificial intelligence can be done by using the old tools, whatever we have. They do a machine learning, all the older tools, and then you take only limited number of data points from those older tools for diagnosing autism and pick up only those questions which have better sensitivity and specificity, so as to reduce the patient number time of the administration of the tools. So you can use the older tools only, or you can use a novel observation data. These children try to look on more. The typically developing children look more at the right eye, but the ASD children more look on the other side. So the eye tracking thing has come up, and now eye tracking is being used for screening the symptoms of children with autism. And we have developed, along with the University of Reading, this eye tracking device along with other data into a START kind of software which has been published and is ready to use for picking up these patients. So these are things which are there. And also along with University of Birkbeck, this eye tracking assessment of children with autism. And along with IIT Kanpur, we have developed this emotion recognition. There is an Indian effective picture database has been developed, and we found that these children, happiness is the easiest emotion they could recognize. Fear was the most difficult. So these are something important. And in the West, they are trying to develop mobile-based. Parents just put the mobile of the child's behavior, and their software analyzes whether the child has autism or not. That is, we don't have that much time. We are also seeing videos, but we cannot analyze in detail. So they are having software developed, and behavior imaging also has been done the same way. And this is the first FDA has authorized only first diagnostic aid for autism is CognoOva, in which you have few questions for the parents and they just put us the video of the child, and it has good sensitivity and specificity. Then coming for the intervention, they are also putting the superpower glass interaction, in which you have this glass which is from where you increase the recognition of emotions. And robotics is coming in a big way. Robots are multiple kinds. You have humanoid robots. We are working on humanoid robots. You may also have parrot robots. You may have somebody like a, you may have somebody like a puppet. You may have somebody like, many other, pictures can be there. We are working with IIIT, and we have done the diagnostics and developing an intervention which we presented in INSAR this year, International Society for Autism Research. And transcranial magnetic stimulation has a benefit. We have just completed a double-blind RCT which has shown beneficial results in autism with transcranial magnetic stimulation. And screen time, this is something why I wanted to put, we are giving all these devices in the form of all apps and all, and they have shown that somebody who had boys who had screen time more at 1 year had more autism at 3 years, but this was passive. What we are using technology is interactive, and the child is understanding, he's not passively looking at it. Even in those robots, which are social robots, in which the interaction, they are training these autism children. So they are interacting. But one issue with those robots are, one, they are very expensive. Second, when the child is liking to interact with the robot, we do not know whether this child-robot interaction will translate into child-human interaction. We are not sure of that. So something like that. For SLD, they are trying to understand what's causing SLD, and there are certain, for dyslexia, speech synthesizers and all are there. They're all available. For typing thing, for dysgraphia, some things are there for typing and spellings. For dyscalculia, you have calculators. We had developed for a dyslexia, we had developed a remedial intervention program, and we had shown that it improved. This was the post-minus pre-fMRI, and they had shown improvement in the fMRI as well as clinical improvement. We translated that into an AI-based platform, and we have shown that improvement in language networks on fMRI besides clinical improvement. That is available now at www.readable.com. Another 1 or 2 minutes and I've finished. This is the web application address for that, and there are some, for ADHD, there is something, they say that if a child is using more of media, is going to be more hyperactive. So this is a double-edged sword, when we are talking. But then, I think it was here, yeah. So, but when you give computer-assisted instruction, they do well. So whether this technology is helping or not, we don't know. But when we are having, you can have an AI-based hybrid model to diagnose ADHD, and you have various other, these are all models, and they have various applications like calendar apps and task lists and talk-to-text software and all. These are aids for these children with ADHD to function, and they really help. And you can have these available on the internet for free use, and we can pick them up, and they can help. For epilepsy, you can have neuromodulation for transcranial magnetic stimulation. We have completed a study which shows it works. And AI can be used for diagnosis of, and then you have seizure detection, outcome prediction, and treatment, all of them. So AI is coming up. For visually impaired, you have devices. I'm just winding up. You have devices for, it's not moving to the next. Can you let it to move into the next? Yeah. So hearing impaired, there are devices, and there are devices for speech and language disorders. And we're working with CDAC for brain-computer interface, and also virtual reality and fMRI-based evaluation. And one more thing, which will be of interest to developmental pediatrician, we are linking the screening tool with the diagnostic tools with intervention packages on a AI-based platform. And this which we are working. Can you just allow me to move next 1 or 2 slides left, please? Yeah, and the days of precision medicine works based on genetics plus individual factors, and we have, for CP, we have some specific precision medicine depending on the, basically for CP mimics. You also have for epilepsy, and and you also have for autism. In autism, one thing is you should remember that, this is something important. You have genetic factors. You have environmental factors like air pollution and pesticide exposure, plus epigenetic factors. In the form of, we have studied the father's sperm epigenome had methylation defects. So these things have important to be studied. And there is a precision medicine There's some issue with the vitamin D and all that we have seen. And another thing is gut microbiome is different of these children than their siblings, which we have found, and we're doing a RCT for probiotics we have done. And they are now saying you can have individualized therapies for autism depending on what their genetic is. We have done heavy metal and another 30 seconds and it's done. Heavy metal and EG, we have tried to do quantitative EG, we have found some biomarkers in that. And this fathers, I told you already, paternal advanced age, because of the quality of life and stresses we all have, is affecting the sperm epigenome, which is affecting the child having autism. So this is, there are some precision medicine targets for autism, but something is, there are only few medicines which are there, and we have to have a minimum 4.5% CARs to change. When we can call it significant, this we had done with elicitation workshop, and there are a lot of softwares and all developed from the IGIB. Nanotechnology is something of future, and stem cell is a total no-no right now, and it's totally no-no right now, only in research mode. We are doing exosomes in autism in ASD mice, and it's not moving. Yeah, and we'll have to trying to work on non coding RNAs. I think 1 or 2 slides are only left. Can you just, yeah. So pre-IGD is something important, pre-implantation genetic screening and diagnosis, but right now for autism it's very far-fetched because we don't know what exactly is causing it, and it will be taking some time. Currently in India we have only for thalassemia PIGDs available, but it is something which is going to come up right now for GDD first, and then coming for autism in the near future. And I think we have to, you can make mobile applications for helping these patients, and so we have to prevent this disease from occurring actually, and pick them up early. That is what is important, and I'm really grateful to all the families and the parents who have contributed to all the studies which have been doing, and our partners in the thing. And we have to understand what the child is capable of and move ahead in that. And it's important to understand this, I'll forget about this, that neurodiversity is there now. Nobody is special needs and all, everybody's diverse, and humanism is something I wanted to put it across. We should be humanistic. This I wrote as an editor. I'm editor of Autism Journal. I'm the only Asian right now as the editor. So we've written in this neurodiversity and humanism, which is not there. And when the world says give up, hope this first, try it one more time, and differently able can definitely challenge the world. And this is my team. Last slide. Last is my thank you slide. This is my team and the institute where I work. This was Foundation Day, and that was for Autism Awareness Month in 2017 when we had lit the Ames blue. Thank you for your patient listening, and sorry for having taken 3 minutes.
Thank you, ma'am. We were just traveling along with you in Shatabdi Express for the past 20 minutes, and we're really amazed by the amount of work you have done in developmental pediatrics with technology. And I, as a pediatrician, senior pediatrician, I feel I am in a developing India, whereas you are already in a developed India. Because I don't know when we are going to get access to all these tools, and it might require a one-day workshop to know what are all the tools available with you, which we can have access. Probably on a one-to-one basis, we can definitely get access to madam, and we will definitely call you for one-day workshop, madam. One small question I have, madam. I think after that I'm not going to allow question because you're short of time. So many educational apps we have. But for us, speech therapy is the most challenging one, and patients have to pay 1,200 to 1,500 rupees for one session. Do you have any particular app which can improve the language skill?
We are making one app.
Name of the app, at least.
No, we are making an app. It's not been launched, but we have decided the name that's going to be Zuban or something. We have not launched it. That app we are making, which I didn't tell you in the last slide. We at WHO, we are making a package. I told you screening tool, diagnostic intervention. What we are doing is, you will diagnose, the professionals will diagnose and put everything on the software, and then depending on the problems, you will have videos for parents coming up on their platform that
please
we are developing with WHO.
Madam. When you please,
and anything what we have developed is for everybody to use. For everybody to use, just mail to me my name and gmail.com, and it's a double F, If you write a single F, it will bounce back.
Madam. Whether it's a paid or unpaid,
no, everything is unpaid.
Unpaid, okay.
Means everything which I do is going to be not paid for.
Thank
it is
you
going
so
to be
much,
free.
madam. Thank you so much.
It is for these children and for everybody across India, and for anybody you need for any parent information thing, please just mail to me, and then you can translate into your regional language. You can even modify if there's something wrong. You can tell me, we can change that.
Thank you very much, madam. Thank you. I have never heard such a wonderful lecture so far. Thank you, madam.
Thank you.